Welcome everybody to our trauma interest work group forced migration speaker series. Our mission is promoting the scientific interdisciplinary understanding of trauma to improve health equity on the South Side of Chicago and beyond. And we do this through education, scholarship, clinical care, community engagement, and advocacy. Just a few housekeeping notes for our talk today. Please mute yourself, of course, and you can ask questions in the chat box during the presentation or use the raise your hand feature during the Q&A. The event is being recorded. I'm sure you had to assent, and video will be available on the Mansueto Institute's YouTube channel afterwards. You can sign up for our listserv at list.uchicago.edu and select Trauma Interest WG. And we are going to be having a brown bag speaker in arts and resilience series. It will continue in the winter and spring quarter, and details are forthcoming. So today it is my pleasure to introduce our two speakers for their talk, Designing and Testing Interventions to Improve Humanitarian Response. So today we have Jeannie Annan and Britt Titus. And I will it looks like I pulled up the wrong, there it is. Nope. Pardon me. I pulled up the wrong email to introduce Jeannie. It was the description of the talk. So I'm just pulling it up again. Here we go. Jeannie Annan is the International Rescue Committee's Chief Research and Innovation Officer, leading the agency's efforts to design, test, and scale life-changing solutions for people affected by conflict and disaster. Jeannie co-founded the Airbell Impact Lab, a team of researchers, designers, behavioral scientists, strategists, and analysts working with technical experts, frontline staff, and partners to find high-impact and scalable products and services in more than 30 crisis-affected countries around the world. Dr. Annan's own research focus has been to develop and test economic, behavioral, and mental health interventions to prevent violence and to mitigate its psychological and social consequences on women and children. She started her career leading education and psychosocial programming in Kosovo, northern Uganda, and southern Sudan. She is a senior research associate at the Harris School of Public Policy at the University of Chicago, and she is also a research affiliate at Innovations for Poverty Action, where she leads their initiatives on humanitarian and forced displacement and on intimate partner violence. She holds a PhD in counseling psychology from Indiana University, Bloomington, and she was a postdoctorate fellow at Yale University and NYU, and a visiting scientist at the Harvard T.C. Chan School of Public Health. And joining her today is Britt Titus, who is the Behavioral Insights Lead at the International Rescue Committee. To date, she has spent half of her career as a humanitarian aid worker, responding to global emergencies, and the other half as behavioral scientist studying human behavior and decision-making. In her role at the IRC, her interests lie at the intersection of these two areas, as she works to embed behavioral science into humanitarian research and innovation projects, with the aim of improving outcomes in education, women's health, mental health, climate adaptation, and malnutrition. Thank you both so much for joining us today, and I will turn it over to you now.
Thank you. Thanks so much, Yael, and others at the Mansueto Institute. And really nice to be here with all of you. I was saying I had seen the other blurbs for other presentations the last couple of months on forced migration, and really sorry I hadn't been able to join the previous ones, but hope to in the future. And thanks for that introduction, Yael. So today what Britt and I thought we would talk you through is, one, I thought I would start with just a broad overview of kind of where things sit in the broad humanitarian landscape and what IRC, the International Rescue Committee, does to kind of place the work and then why we started the Arabella Impact Lab, or Research and Innovation at IRC. And then Britt will lead through an example of a project that is looking at uptake for mental health services and in Jordan, to highlight both how we work, but also I thought it was an interesting project to highlight for this group, and really look forward to the discussion, questions, and any feedback or learning from different projects that you're all working on. So I'll start by, I guess, first saying that I want to place this in the context of humanitarian crises. I don't think it'll be a surprise to anyone, but we really are at an unprecedented level of humanitarian crisis that is only growing right now. I was recently, a couple of weeks ago, in Somalia, and it's it was such a striking example there of these different factors at play. One, decades of conflict, and then climate change related disaster coming together to not only drive very high levels of displacement within the country and outside of the country, but also to just put people further on the edge in terms of vulnerability across a wide range of outcomes. So that obviously has psychological impacts directly, but then also has a lot of impacts on the risk and protective factors that people have. And so we're just seeing this incredibly high levels and only growing levels of humanitarian crisis. Just to put that in numbers, a couple of kind of high level numbers. Next slide, Britt. So it's estimated around 300 million people in current humanitarian need across the globe, 100 million displaced from their homes, both within their own countries and outside of countries. This number, I think, is actually older now. I think it's more like 200 million children chronically out of school, so not just out of school for short periods of time. 18 million children every year acutely malnourished in these humanitarian settings, and 2.5 million newborns die at rates that have not really moved and improved compared to the rest of the world, where we've seen real improvements in maternal and newborn care. Next slide. So IRC, the International Rescue Committee, has been around it's coming on 100 years, and responds across a really wide range of outcomes. So our 5 broad outcomes include health, safety, education, economic well-being, and power. Mental health and psychosocial well-being really sits across health, safety, and education for us in terms of where those programs and those outcomes sit. And so our programs are responding across all these different outcome areas. And we are in, next slide, we're in around 40 countries, so responding to crises kind of as diverse as Afghanistan. That's both in terms of the current situation in Taliban-ruled Afghanistan, but also the evacuation and resettlement of many Afghans in the US and in other countries. The Syria, now over a decade-long Syria crisis, the Ukraine crisis in surrounding countries, numerous crises in sub-Saharan Africa, Venezuelan crisis, North Central America, and then we resettle refugee, and this is in providing that broad range of services for those outcomes. And then we resettle refugees in the US across over 20 cities, and in a few countries in Europe that's growing. Our main resettlement is within the US. Next. We just had our annual report come out. So I thought this would just give a snapshot of kind of who and how we're reaching people. So current reach is about 30 over 30 million people across the countries that we work in, providing over 350,000 children with education programs, over 2.5 million people with water assistance, over 150,000 with malnutrition treatment. We've resettled people from 32 countries in the US, but this year those were predominantly, that 85% predominantly driven from Afghanistan, DRC, Syria, and Iraq. And then have programs in terms of our European arm in Greece, Italy, Serbia, Germany, and the UK. So that just gives a brief snapshot. And then in terms of our programming, which again, I'll give an overview before we dive into one project, our mental health and psychosocial programming that we do spans across, next slide, a range. Sorry, this is probably on screen. It's really hard to read. I realize I was looking on my big screen, but across 4 different layers of the kind of mental health psychosocial pyramid. And so from providing basic services and security, like basic psychosocial support or referrals, to community and family supports, and like a lot of our education programs as a basis include social and emotional learning programming. We also do parenting programs to help parents support their children, and have safe spaces within some of the displaced settlements. In that 3rd layer, we do group approaches, largely for interpersonal or for therapy, and do direct case management, individual case management, and then some but minor specialized services, so some psychotropic medication or clinical care coordination. So that just gives a sense of the broad range of our programs for mental health psychosocial support. And then last thing I'll share about is Arabelle Impact Lab. So given this growing need for the humanitarian need, really unprecedented levels, and not a growing increase in budget for humanitarian response, there is a need now more than ever to create products, services, delivery systems that improve both the impact that interventions have, but also their scalability. And so we are seeing this huge gap, and what we do at Arabelle Impact Lab, which is synonymous with our research and innovation department at IRC, is to design and or adapt new or interventions that have been done in other areas to try to really improve that impact and scalability of different programs. We work across all those 5 outcome areas that I named, but we have 4 areas of focus. Next slide. The first is treating acute malnutrition. The second is delivering last mile education. The third is saving newborn lives and empowering women. So that's sexual, reproductive, maternal, newborn health. And last is advancing climate resilient agriculture. So 4 pretty different areas of priority. So with that, I will hand over to Britt to walk you. Oh, sorry, one more thing. This won't be new to any of you who do work on research, but our process is to go from idea to prototype to pilot to rigorously evaluate and to scale. We try to bring together the best of both the kind of prototyping and iteration of the private sector with the rigorous studying of the academic world in a humanitarian organization. And ideas come from our frontline staff, from partners, from communities. We're indifferent in terms of where those ideas come from and want them to come from a wide range of places. And also scale isn't about necessarily IRC implementing the program. So often scale means that it's a program that a government implements, or private sector, or a range of different NGOs, either some combination of local and international. So with that, now I will hand to Britt to walk us through one example that's gone through this process, is going through this process and focused on uptake of mental health services. So over to you, Britt.
Thanks, Jeannie. Great. So, as I'm sure is not a surprise to any of you who work in this field, we have a growing body of evidence that suggests, there's this really outsized impact of mental health issues in the refugee population in places that we work. And, you know, the most common mental health disorders, things like anxiety, depression, post-traumatic stress disorder, tend to double during emergencies and impact the most vulnerable. And as we know, this is also a self-reinforcing cycle that can make it very difficult for people to rebuild after facing trauma of displacement, conflict, and crisis. And in places like Jordan, which is the country that I'm going to be talking about today, it hosts over, I think, 1 million at least refugees, and mental health is still such a taboo topic, and that poses a lot of very significant cultural barriers to identifying need and addressing, you know, care in these populations, both the refugee and the host population. So in March 2019, in response to the COVID-19 pandemic, the Jordanian government imposed one of the strictest lockdowns in the world. And this compounded mental health issues for the most vulnerable people, again, both in the host population and the refugee population. And so in response to that, the IRC started testing a digital campaign, which they called Infor-MH, Information for Mental Health, that was really at first aimed around kind of bridging the information gaps around mental health and trying to address stigma around mental health. And that was really the beginning of a project that is now in its third year and has gone well beyond COVID and well beyond kind of information sharing, and is well into kind of you know, study phases. So I'm going to be telling you a little bit more about that now. So a little bit about the need. So in Jordan, surveys from even before the pandemic indicated that around 57% of refugees and almost 34% of Jordanians were experiencing lasting distress. And yet only 5% of people had ever sought out any form of care for that mental health distress. So this gap of around 95% of people who have these you know, mental health conditions who are not being treated and not seeking care is something that we wanted to address in this project, obviously compounded by the triple threat of COVID-19, displacement, and poverty. So Infor-MH, developed by the Erbil Impact Lab, aims to really bridge that health treatment gap and at its intersection in poverty and marginalization in Jordan. And so while we feel that there are many interventions that focus on the supply of mental health treatment and funding providers launching hotlines, different types of formal care offerings in Jordan, Infor-MH is trying to address also the demand for these services. In order to do that, we've drawn on the field of behavioral science, which is the field that I work in, to try and help people seek out the care that already exists rather than duplicating the existing treatment options that already exist in country. And so behavioral science, for those of you who may not be familiar with it, is essentially just a study of how people behave and how they make decisions in populations. It's really interdisciplinary, so drawn from psychology, economics, neuroscience, and other social sciences, and tries to use evidence from both the conscious and non-conscious drivers of human behaviors to address issues like uptake of mental health services. And in this case, it can help us try to close that gap between existing resources and need, and try and strengthen the mental health situation in Jordan. So since the beginning of this project, we've been conducting quite a lot of qualitative research, extensive interviews with both practitioners and service providers, as well as with clients, to try and understand really what are these barriers that are preventing people from seeking out the care that exists, and what might be opportunities and drivers that we can leverage in order to build a really concrete program. So there are many, of course, so many that would, you know, take up a whole presentation, I'm sure, but a few snapshots is that, you know, many people in Jordan don't know that what they're experiencing is something that could benefit from mental health care. There is a lot of stigma around mental health care, as I'm sure you can all imagine, and is present in many countries, where this idea of mental health care is really seen as something for people who have the most severe forms of distress. So immediately people think of, oh, what mental health care is for people who are really, really ill or need psychiatry only, and is not for people like me. And, you know, for good reason, in many cases, there is kind of, you know, a lack of trust in some of the health services and mental health services that do exist in country. And finally, where people do finally overcome those kind of psychological hurdles to seeking out care, often, you know, some of that care that is available isn't always formal care, and it isn't always of the kind of quality that we would want. So these are some barriers. Of course, there are many, many more. Some drivers is that we found out that most people who are experiencing distress and know that they're experiencing distress are more likely to seek out informal care through friends or family first, before they'll seek out any kind of formal care at all. And, you know, oftentimes we also noted that, you know, people might be experiencing the somatic symptoms of distress first, such as sleeplessness or digestive issues. And those are things that they would be more likely to go to a pharmacy for and try and get, you know, medication to help them sleep better, or deal with digestive issues. And so we noticed there was an opportunity to kind of intercept people there at a pharmacy where they're already seeking out support, but may not know that it is related to their mental health. Again, people, you know, who did access care, you know, usually mention that they had someone in their life who was more knowledgeable about these topics, who was able to kind of say to them, you know, this sounds like something that would benefit from mental health care support. And again, the top kind of methods of getting new information typically end up being, you know, social media, with the most trusted one that we hear over and over again being WhatsApp. So that is where we have focused our support, because we want this to be a project that works at scale for the wider population, and so have been looking at the most kind of scalable entry points for an intervention. So what did we design? So one of the first things that we learned after a lot of kind of consultations with different stakeholders is that, you know, people often don't know, first of all, that they might benefit from mental health care support, but two, there's so many different pathways within the country, and there's so many different options that, you know, what a lot of people told us who work within the mental health space in Jordan is that they really wanted to see some kind of tailored recommendations for people. So some kind of directed pathway that could help people navigate this kind of very complex system of, you know, informal and formal care options, and really help people not to diagnose them, but to help recommend what might be kind of the best kind of care pathway for them within the country. So one of the things that we developed first was a self-screener. And so the self-screener really tries to direct people to the type of care that might be most appropriate for them, depending on their levels of distress and well-being. And what we've tried to test over the last year is a digital self-screener that can be delivered on social media platforms, using an online tool to kind of collect information, and then give people, again, not results to diagnose them, but, you know, based on your levels of distress and well-being, we recommend, for example, that you, you know, seek out this option versus something else that might not be as appropriate for them. So when we tested this type of intervention in Jordan, we got a lot of really interesting feedback. So people really were able to use this self-assessment on their own without too much guidance, which was a really positive piece of feedback. But we also found that some of the questions were not that easy to answer. For example, we drew from already validated tools like the WHO-5. Some of the questions weren't, you know, kind of culturally adapted. And so we did a lot of work of kind of helping provide, for example, additional examples or cultural context that might help them with the question and how to answer it. And people also really liked having some kind of image or diagram or even emojis to help them be able to answer some of the questions. Another thing that we wanted to use were behavioral interventions, so messaging and reminders drawn from the behavioral science evidence base to encourage people to follow through with the recommendations we were giving them. So sometimes, you know, where people were falling maybe on the higher levels of distress and lower levels of well-being, we really felt it was important for them to seek out more kind of formal levels of care. So calling a mental health hotline to be referred to a psychologist. But we know that there are a lot of kind of psychological and behavioral barriers preventing people from doing that, even where they are kind of that is the, recommended kind of path of action for them. And so we wanted to, draw upon behavioral science to try and encourage people to take up that care. And so from our ongoing testing and prototyping, we learned that, people really responded well to empathetic and normalizing language that speaks to the fact that distress is a very common and normal experience. Again, this destigmatizing language. We also kind of got really positive feedback about how, care seeking, this type of care seeking is really recommended by experts and even doctors, since we know that those are, authority figures. And then finally, the importance of kind of showing peer feedback that other people like them are doing this, are kind of investing in their mental health care, because again, that's something that is still quite taboo, and people feel quite strange and uncomfortable with seeking this out. Sorry, there's some messaging there. Next, we also wanted to use some self-directed care strategies that can improve well-being, based on the kind of evidence that we have that this can be quite effective, especially for people who might not be able or willing to seek out, formal and informal care immediately. We felt like it was important to help people invest in their own well-being by using their, self-care strategies. So in our last round of testing, after iterating and testing and improving, we ended up with a few categories. So body, soul, mind, and connection. So tips around, physical exercise, investing in personal relationships and family and friends, those types of proven well-being strategies. And so things that people really liked were really practical, easy to implement activities that they could kind of use the next day. So things that were not too abstract. So things like going on a walk every single day or praying were things that were really well responded to, as well as things that were backed by scientific evidence. We also found, again, that one of the best ways of kind of interacting with this population was WhatsApp. So again and again, we heard that's where, you'll reach people. And so we wanted to kind of test these interventions on WhatsApp to see if that would be feasible. So for the last few months, we've actually been using a Brazilian-based tech company that we were already partnered with at IRC to test out if we could deliver all of this as one kind of complete journey on WhatsApp, where people already are and where they're likely to feel comfortable engaging. We also know that not everybody, we're not going to be able to reach everyone in the population digitally and online. There are a lot of people who, for example, people in the older population or more rural areas that are not going to, be active on social media. And so we've been testing reaching out to those people in pharmacies. So earlier this year, we were able to work with a number of pharmacies over a period of weeks and distribute over 3,000 kind of brochures about the program, and kind of see if people took them up, if they took them home, if they kind of, followed through with, going onto our website from the pharmacy brochures, etc. And finally, connecting to formal and informal providers. So again, a big part of this project is connecting people to the care that does exist. And so we were able to find two really great partners in country that we've been testing, connecting people with. One is for formal care. So that's a mental health hotline that we've had pretty good endorsement and feedback from the wider community in Jordan. And also an informal care provider. A lot of people told us that they might not feel comfortable seeking out formal care, but what they actually really wanted was like an in-person, community-based support network, something like a group counseling in-person group. So that's something that we found through a partner called Questscope, and we've been testing linking people to that as well. So that's a lot of components. The way that it all kind of merges together in theory is that we are targeting people who are experiencing psychological distress. We hope to meet them or find them both online and offline. So on digital means, so using Facebook and WhatsApp to kind of bring them into this journey. And then secondly, in physical spaces like pharmacies, clinics, cafes, those kind of informal spaces where we know that people may already be talking about mental health, even if they're not talking about it in the words that we would use. And then once we've kind of reached them, we would be hoping to kind of offer them this very short self-assessment in order to recommend specific kind of care pathways for them, depending depending on where they might fall on distress and well-being indicators. And then we would be implementing this package. So everyone would kind of get kind of psychoeducation content. Everyone would get, in behavioral and reminders and messaging to try and encourage people to seek out the care they are recommended. And then, of course, people would be recommended to take up, either self-directed well-being strategies, informal care pathways like a community support group, or that formal care option for people who are experiencing higher levels of distress. And ultimately, we hope that this will result in less stigma, more people seeking out care that do exist, more people engaging in self-care practices, and even some people being able to actually provide psychological first aid to other people in their lives. So we learned a lot. For example, as I mentioned, we learned a lot about what type of behavioral messaging might be encouraging for people to take up this care. So we actually, earlier this year, we wanted to conduct a A/B test to compare two different message framings that we had already received a lot of positive feedback on, to learn which one was more effective at actually leading to behavior change. So we ran this A/B test on Facebook. We were able to reach over 400,000 people who saw our A/B test, and we had about 10,000 people click through to our website. And what we were measuring was, one, which of these two message framings would lead to more people clicking on the link, which would take them to our website to give them more information. Once they were on the website, would they stay? Would they read actually and engage with the content that was there? Or would they quickly drop off? And also we had a button there that they could actually click to call to get care. So we actually wanted to measure how many people would click on the button and call and seek out support, depending on which messaging they got. So I'm going to make this a little interactive. I'm going to explain these two options, and in the chat you can tell me, or everyone can vote, which one they thought was more effective. So option A was on the left-hand side. And that one was really based on a lot of feedback we'd heard that people said, that it was very effective when we kind of backed up what we were saying with evidence, when we showed that it was kind of expert recommended, that we either had doctors or professionals kind of saying this type of care pathway is recommended and there is evidence that it works, using a lot of kind of mentions of data and what professionals are saying. Whereas option B, again, we'd had a lot of feedback in our testing qualitatively that people really responded well when we said that other people in Jordan are starting to change their behavior. Other people just like you are starting to take up these new steps of investing in their well-being. And actually, like 7 in 10 people said that they would likely, seek out that care, which is true. And so really focusing on what peers are saying. So I'll give everyone 20 seconds. And if you write in the chat and say which one you think led to more engagement, more clicks, more calls to action. And then we'll see who was right. Okay, should have known better than to do this with psychologists. Okay, we have 3 votes. Any final votes? Okay. Okay, well, you're all right. So congrats. So yes, B was more effective. Option B had 14% more unique visitors to the website. The visitors who arrived on option B spent 33% more time on the website. And we actually had 30% more clicks to the call the mental health hotline, although that one was not statistically significant. There weren't that many people we ended up with who called the hotline. So we still had more work to do. But what was really useful about this is kind of figuring out what was the kind of more effective framing, so we could weave that throughout the entire program and make sure that we were using that peer endorsement at every moment that we could kind of engage with people. So we took all of these insights that we've been gathering over the last 3 years, and we wanted to actually test them as a package together to see what happens, when we include that framing, we put it all on WhatsApp, we use that psychoeducation content, we'll use all of it together with the self-screener and see how it works. So we've just been kind of wrapping that up with 30 people in one area of Jordan. and getting some really interesting feedback. We just did a midline kind of call with people, and most people say either they feel like it's really good or excellent, or at least helpful and benefiting them in some way, and just a few people saying it's all right and have some kind of constructive criticism to share with us, which is what we want. So we really trying to get as much of that constructive feedback as possible so we can make improvements. Some of the positives that are really wonderful to hear is that a lot of people told us that they really feel cared about. And so getting these regular messages right to their phone actually gave them the sense that someone cares about them, even though it's being delivered through a bot. And so that was really interesting to hear that was one of the main things that people really liked about it, is just knowing that someone's following up with them and cares about their mental health and distress. Also, people saying, oh, they got a lot of interest in learning about themselves, and the self-assessment really helped them understand themselves more. The self-directed well-being tips were the things that were the most taken up, and people actually said they were able to start implementing them immediately and already felt better for, for example, going on walks and calling their friends and investing in kind of sharing their mental health distress concerns with people around them. But obviously there were also some issues and challenges, things like glitches with the tech, with the WhatsApp bot. Not everyone was illiterate. So one man said that he had to have his wife read every message out to him, which is quite sweet. But we're hoping to kind of create an audio version of this so people can hear the messages as well as read them. People are always concerned about confidentiality and really concerned that someone will find out that they're, engaging in this. So we're doing a lot on that front. And also people saying it's too early to judge. It's only been a few weeks. I can't see any impacts now. I can't see any changes in my life necessarily. So just to wrap up quickly, what we think makes this project different than other projects is, one, that it's designed for scale. So we've already in our work, reached people through social media, millions of times with our campaign. So we think that, using social media and these online kind of entry points is really a great opportunity to really reach the most people who are in need. Two, using behavioral insights and data science. So we've really used a very behavioral science and data-driven approach to really understand what is preventing people from seeking out this care, and how can we change that. We feel like this is filling gaps that are not currently being addressed in the system. So one of the things that's unique to this project is we're targeting everyone in Jordan, not just the people who are experiencing the most severe forms of distress, which tend to be, there tends to be more investment in that area, especially in humanitarian work, addressing people who have the highest kind of symptoms of distress. And we're also looking at, all the people who are experiencing mild and moderate symptoms of distress as well, and linking to existing care. And finally, we're trying to meet people where they are rather than create a parallel program. So we know that people are already going to pharmacies, they're already talking to their friends and family, they're already on WhatsApp. And so we're trying to really create a program that meets them in their current lives rather than asking them to kind of fit into a new system, to try and lessen burden on them and also lessen burden on the formal health care system that already exists. So where are we in the project now? We've just finished the design, or we're just finishing up this month, the design phase, which has included all that ideation, co-design, that campaign, the A/B testing. We've done iterative user testing with over 115 people and just completed this kind of package test of all of these components together with 30 people. And then next steps that we're trying to fundraise for and get kind of research partners who might be interested in working with us is to do a pilot study, an operational large-scale pilot, to kind of do a test run of the whole thing. We are also fundraising to do an RCT to actually measure outcomes in a more robust way. And then ultimately, we're interested in kind of a path to scale nationwide, with the potential of benefiting over a million people in Jordan with unmet mental health needs. So yeah, that's everything from this project. Thank you so much for listening, and look forward to hearing what questions you might have.
Thank you so much, Britt and Jeannie. That is, it's fascinating to hear about this work, because, it's not covered in the popular media necessarily. And it's interesting to hear what is happening in other countries when we can't read about it so easily. I wanted to start us off just with a question about how you see this work in terms of the larger framework of trauma. So my that most of the population that you're talking about were displaced in 1948 from Palestine. Is that right? Are they people living in refugee camps since then, since 1948? Do you know?
Britt, do you want to take that? It's a combination. Sorry, in terms of Jordan, the displaced population is refugees, Palestinian refugees, but also the large proportion that IRC works with and that this would be reaching, but as Britt said, it's not targeted only for refugees, are Syrian refugees. And then there are refugees, so from the last 11 years of the conflict, many of those displaced in the early years, but not all. And then there are refugees from other countries beyond that, but that's the majority.
So when you're talking to folks, do you put into context, I mean, you could look at this and just say, oh, wow, this is randomly a population that has high levels of anxiety and depression, right? But this is generational trauma for a portion of them, right? This is families who have raised multiple generations in refugee camps. If we're talking about 1948, if we're talking about Syria, displacement with little hope of return that is foreseeable. So is that a way that you also normalize symptoms for people? Do you talk about, do you take any kind of like trauma-informed approach, or are you just sort of approaching them with like immediate sort of, these are high rates of depression and anxiety in this community, let us help?
I mean, and I can say what we do in Jordan. I mean, we actually have to be pretty careful about even mentioning mental health because it's so stigmatized that actually when we even mention things like mental health, it's immediately seen as, oh, they're going to give us, they're going to kind of put us in an institution and force us to take medication that we don't want to take. Like that is, for a lot of people, that's the immediate association with mental health. So we actually have to be really careful about how we talk about it. And oftentimes sometimes we're just talking about more kind of positive framings of well-being improvements and improvements to life. And another, approach that's been useful from the behavioral science side is kind of drawing on these social norms that Royce was talking about in the chat with going with the crowd because everyone chose B, really using these kind of what we call dynamic social norms to say like to people, one, this is normal because, we even using the fact that COVID made things harder for everyone has been effective. So saying this has been a really tough few years for everyone. People have responded really well to that because it's something that's universal and doesn't make them feel like they've done anything wrong. And then secondly, to say that, things are changing. We've seen and you saw one of the messages, a 52% increase in people seeking out mental health care. And that kind of fact or that statistic has really resonated with people because people are then able to say, oh, well, it's other people too. And there must be a reason in Jordan why this is happening. And it's not just me. And so I think, that type of normalizing language and not focusing too much on the symptoms or the distress or the conditions. We don't actually mention depression, trauma, or anything actually to people because people don't like to think that that's something happening to them, but more just talking about how things are changing and that it's, totally normal to be having a tough time. So that's what we've been finding good success with in Jordan, but curious if Jeannie has any thoughts.
I'll just add that in the broader mental health and psychosocial work that IRC does, one, just to be really clear about this, these are Jordanian or Syrian providers, who are and staff who are doing this work, not psychologists or psychiatrists flying in from elsewhere doing this. So that's one, but the other is that part of that layered care definitely is psychoeducation, including the normalization of symptoms, particularly when there are high levels of either displacement or experiences of violence. And so it depends on the context, how that is talked about and how the symptoms are talked about in relevant ways. So that's really adapted context by context and country by country, depending on what the experiences are, which I think, yeah, is part of your point. Both is it a trauma informed, and is it taking into account the various experiences that people have, and so that's done differently in the different countries where we work. Royce, it looks like you unmuted.
Yeah, a question. What has it been like, and what have you learned about how mental health care is usually administered in Jordan? Like, what kind of system, and is it? I'm just curious what that's been like.
I can share a few things. I'm not a mental health expert, but some things that we've learned about how it is delivered is it's a real mix. There are some really, really great services and really great providers, and then there's others that are not so great. And so that kind of like high variability in quality provision is something that we've really had to grapple with. Especially because we are linking people to care and we're not providing that care ourselves in this project specifically. So a lot of this project has really been trying to find those one or two partners that we feel really confident about, and that can provide care across the board. But a big challenge we face is that people have, in many cases, had negative experiences in the past, or they've heard of other people having negative experiences in the past, either where, one, they feel like someone's going to force them to take medication. That's a common one. Two, that services might not be available in their area. So there are some areas that have more care provision than others, and certain areas within the country that have that. But if you happen to live in another part, you might, call and go through all the steps of seeking it out, only to find out that there's nothing available to you, or that you'd have to pay to kind of take transport to somewhere that's kind of far away. And so and this kind of feeling that, like, some engagements that people have been not great with kind of service providers. And so, a lot of it is one, managing expectations from our side, two, like really trying to make sure that we find the few people that, the few kind of providers in Jordan that we know are, going to be available at scale. And also we really believe, based on kind of the general space, that these are really trusted, and we can kind of trust the quality of care that they're going to provide. And managing expectations around it, and reducing kind of the negative reputation that some of these providers have. So that's the kind of space that we're offering. I can't speak to the kind of mapping within Jordan of what's everything that's available, but it's really a mix of different types of care. And again, has in the past tended to focus more on the people with the most severe forms of distress. And so that's why we're taking this slightly different approach.
And just to add, the only thing I'll add is WHO has been a key partner for us in that mapping of the services and giving a sense of the quality. So we understood this to be a gap in the uptake and demand for services that we could help support to fill. And so we've been working really closely with WHO and a mental health working group that consists of many of those partners who are providing services, but WHO has been the one doing the kind of quality assurance and side of it, so that then we make sure that we're linking only to the ones, as Britt said, that are seen as quality providers.
Well, those challenges sound familiar, right? So I not that different from the process here in the States, but I'm sure there are differences. Like, one thing I'm curious about is like the balance of psychotherapists and counselors seen as mental health providers versus purely prescribing psychiatrists. I think in the United States, part of the mental health culture is a sort of decentralized approach to mental health, right? Where there are psychiatrists, but there are also a large number of non-psychiatrists and non-nurse mental health practitioners, which makes counseling fairly widely available with, important caveats. Some countries that's not true. So I'm curious if what you've noticed about psychotherapy versus medications in this population.
I don't think I can speak to that, but maybe Jeannie, you can speak a little bit about any understanding.
It's a great question. I think in the initial mapping, we would have those numbers, but we'd have to, I don't have those numbers in most of the contexts that we work in. There are very, very small numbers of psychiatrists. Jordan is one where, so I don't have the numbers, but there would be some psychiatrists. There would be fewer therapists, and then fewest psychiatrists, some therapists, and then the NGOs serving the Syrian refugee population in particular are largely providing group-based therapy, and then some medication mostly through primary health care. And so that's the kind of general breakdown. I don't have we would have the map somewhere of those numbers, but that would be the case. In a number of other countries, the challenge that we face in terms of programming is a real lack of providers with almost any training. And so there we have done training, for example, of CPT or other group-based therapies to lay workers who have almost no have no psychological training. Some of them haven't, in DR Congo, we did it with women who many of them hadn't finished high school, and we're still able to do it. So sorry, I'm answering a different question from the Jordan question, but in many of the countries where we work, we're looking at a lay population delivering services, or through the primary healthcare. Jordan has a slightly more robust mental health care system than that.
Interesting.
Any other questions, or would love to hear from others who are have similar thoughts? Interesting, because we work in other contexts and don't work in the Chicago area, even though I'm based here. It'd be really interesting to hear any other similar challenges or interventions that of that have been filling this uptake gap in other places.
I can jump in with another one, just briefly. It brought to mind for me when I was thinking about getting buy-in, an example that I learned in public health school, where the CDC was trying to increase uptake of mammography among African American women, where breast cancer rates were high and the rates of mammography were very low. And they did a really successful intervention where they partnered with ministers, church ministers, who preached it from the pulpits, and then actually hosted mammography clinics at church after services. So two things here, what the obvious question is about, in Jordan, if you've had any success in outreach to imams, other religious leaders in other countries, other religious leaders. But also, I noticed in your A/B test that B1 and B showed a secular looking couple, or non-hyper religious, in the illustration, and A was two women wearing hijab. And I wondered if that was to me, that seems like a little bit of a confounding factor there, because if my hypothesis is that more religious people would have less uptake, less openness to mental health interventions, and that less religious people would be more open to it, maybe more secular, more knowledgeable about science. That's my little hypothesis. So anyway, I'll stop talking and let you comment.
Yeah, I can speak on the religious aspect here, and then Jeannie has a great example from Uganda. We tested these images. These images have been tested over and over again, and I think we didn't get any kind of weird thoughts on that. I think maybe the one with the man and the woman kind of in regular clothes is like, it kind of looks like they're at home, and people don't wear necessarily a hijab at, in the home with their husband, whereas the other one is like calling a professional, and it's like they're kind of like it's an engagement with a professional, and so she's wearing a hijab, and so we didn't actually get any kind of comments or anything on that actually when we did testing. But we did at some point do testing to see if religious messaging would help encourage uptake. And we actually kind of tested whether like mentioning things from the Quran, there's about a 95% Muslim population in Jordan. And so we tested whether kind of, including mention from the Quran, about the importance of taking care of oneself in more general terms would be effective. And we got really mixed results. So some people said like, yes, this is great, really love seeing this. This is really, this is, something that, is kind of part of religious practice as well. And prayer and everything is all part of these self-care practices. And we had other people really reacting very strongly that it was not something that they wanted. And there was when we probed further on that, there was a mix of people saying, well, this won't, work for the 5% of the population who aren't Muslim. Like, how are they going to feel? There's going to be a lot of pushback. And then apparently also we learned, which is very contextual, that apparently since the COVID-19 pandemic, there's been a lot of people using religious influence, and a lot of kind of maybe a little bit shadier imams kind of being used to kind of share certain information, or a lot of people embedding kind of information through religious kind of means. And so we actually got quite a few people who said like, oh, not this again, we've had enough of that, like having information being shared via religious means. So with all of that kind of mixed, very positive or very negative, we kind of decided to put a pause on it for now and kind of return to it at a later date. But curious for Jeannie to also share about how we've had great success with this model in other places.
Well, just really briefly, it was we designed a couples counseling session, and through very much a user-centered design process in a number of countries. We ended up doing most of the work in Uganda, and that's where it's scaling. We designed a couples counseling sessions, 16 sessions that couples go through. It's to prevent intimate partner violence, where there are high rates of intimate partner violence. And again, couples said they not only go together to the church to in the highly Christian population, go to church as a couple for counseling. That's where they go for counseling, and where they look to for kind of setting norms about what a husband and a wife should be. So we integrated it in with a number of different churches. Now it's scaling with the Church of Uganda, and we tested it, and it had quite high rates of reduction in intimate partner violence, as well as strengthening of couples relationships. So that was one where we very much went where, again, where the users were saying, this is where we go, this is where we want it. But then we used behavior change and interventions from other intimate partner related, violence related interventions, and integrated it all with scripture, et cetera. So that one's well on its way to scaling across the many Church of Uganda members, which is quite exciting. And I think with that, we're at time, but thank you so much for having us. And it's great to meet this community, and again, hope I can join in the future.
Thank you so much for coming today. We really appreciate you sharing your research, and look forward to continued support of the IRC. And Jeannie, hope to see you soon at one of these talks.
Yes, great.
Thank you, Britt.
Thanks for having us.
Thank you so much. Thank you.